Hi, this is Elliot Fishman, and welcome to our latest vodcast. And this is going to be on a topic that I think is very challenging, and it's adrenal hemorrhage. I'm going to go through the causes of adrenal hemorrhage. I'm going to go through the CT appearances. We all have this great idea of what an adrenal hemorrhage looks like. Usually it's related to trauma, it's oval, it's high density, or Coumadin, and you have a good clinical history. And those indeed are adrenal hemorrhage cases and are classic, but there are so many other causes of adrenal hemorrhage, and it's not an easy diagnosis. It's often what the pathologist tells us is present, but we did not know it preoperative. So I'm going to share with you a lot of the challenging cases that we've seen over the last couple of years. A couple of articles. This is an article we wrote a couple of years ago. Adrenal hematomas with a mass-like configuration offer a potential diagnostic dilemma for radiologists and endocrine surgeons. Although it is rare that adrenal hemorrhage is surgically resected, awareness of the potential appearances of these lesions is important to spare patients from unnecessarily aggressive surgery. Now, that all sounds good and is 100% correct. But the more I do adrenal conference, the more I recognize it's not that simple. Causes of adrenal hemorrhage, non-traumatic causes that is, include stress, bleeding diathesis, including anticoagulant use, procedures, and intratumoral bleeding, which are particularly challenging cases. Stress could include recent surgery, organ failure, sepsis, or pregnancy. These causes are not mutually exclusive and can coexist. Recognition of adrenal hemorrhage is particularly important because of the common use of anticoagulant therapy and the introduction of some of the newer agents. Non-iatrogenic bleeding from processes such as DIC or antiphospholipid syndrome can also lead to adrenal hemorrhage, though those are far more unusual. If I have to make a list of adrenal hemorrhage, Coumadin, trauma, infection, hypercoagulability state, stress, and underlying tumor are some of the things I'm going to put down. Now, of course, sometimes it's an easy diagnosis from the history. The patient has trauma, or the patient has been put on anticoagulant therapy, or the patient is septic. Those are a bit easier, but it's particularly the ones that relate to tumors, particularly those that relate to benign tumors like adenomas, that are particularly challenging. Some other facts with hemorrhage. They can be unilateral or bilateral. Most cases are unilateral. When they're bilateral, they can result in adrenal insufficiency or Addison's crisis. And particularly when they're bilateral, the presentations are very challenging. Patients can present with an acute abdomen. They can present with suspected myocardial infarction or sepsis. Classic CT appearances on non-contrast studies, high attenuation. Depending how recent the bleed is, the high attenuation will be more or less. Again, unilateral or bilateral. Most cases are indeed unilateral. Over time, they can calcify. The adrenal can become small and densely calcified and look similar to processes like TB, or they can be very large lesions with very dense peripheral calcification, and I'll show you some examples a bit later. And interestingly, it's more common in females. Now, in terms of trauma, again, clinical history is helpful. The most common imaging features are a 2 to 3 centimeter oval hematoma, irregular hemorrhage obliterating the gland, periadrenal hemorrhage or fat stranding, and uniform adrenal swelling with increased attenuation. Those are 4 different things. The one I think that we see the most probably is an oval-shaped adrenal, high density with a bit of stranding. It's often and most commonly on the right side and often associated with other organ injuries, particularly liver and maybe even kidney. Now, if you talk about adrenal masses with hemorrhage, this is really where it gets difficult. Pheochromocytoma is the most classic. Probably 10% of pheos will bleed spontaneously, only because the rule of pheos is always the rule of 10. But I've only seen a few cases, to be honest. Metastasis can bleed. I've seen it from lung cancer. I've seen it from melanoma. so it can occur, not that common. Adrenal cortical carcinoma may present with bleed or just bleed at some point during the diagnosis. Myelolipomas classically can bleed. Myelolipomas, if they're symptomatic or if they're over 5 cm, are commonly resected because of the potential for bleeding. And adenomas. I never really thought of adenomas as a lesion that bled, but they can bleed. And when adenomas bleed, we often don't see them in the acute phase, but we see them in the chronic phase where the patient has a scan for a different reason, and you see a big adrenal mass that's of higher attenuation or mixed attenuation. It's not acute blood, and so it's a very difficult diagnostic dilemma. In this article by Jordan, Imaging of Non-Traumatic Adrenal Hemorrhage, some good points. Acute intratumoral hemorrhage, most commonly seen in PHEOs, but again goes through the things we just went over: myelolipomas, METs, ACC, adenomas, and hemangiomas. Interestingly, calcification suggestive of hemorrhage was seen in about a quarter of myelolipomas, but the fact is, I can see punctate calcification in myelolipomas. I rarely see extensive or dense calcification. Prompt diagnosis may matter clinically because up to 50% of patients with bilateral hemorrhage may eventually have life-threatening adrenal insufficiency. So again, when you have bilateral adrenal lesions, and this could be from adenomas, can be bilateral 10% of PHEOs, can be metastasis, but you always have to think about bleeding because when you have bilateral involvement, those are the patients who go into Addisonian crisis. So it's a very challenging diagnosis. It doesn't occur that frequent, but you need to think about that possibility. Other features that may be seen in patients with acute adrenal hemorrhage include periadrenal infiltration, active extravasation with retroperitoneal bleeding. Again, active bleeding in the adrenal is fairly rare. Unenhanced CT in isolation, performed either because of adrenal hemorrhage, is suspected clinically, or because the patient can't get IV contrast, can show enlargement with higher fluid density. So then it becomes almost like any other lesion, be it a renal lesion or a liver lesion, where you see high density and you begin to think about hemorrhage. Another point in the article by Jordan, bleeding often continues until the adrenal glands expands and forms a round or oval hematoma. Hematomas vary from a few centimeters to well over 10 centimeters. A hematoma may appear on CT on non-enhancing lesions in the 50 to 90 Hounsfield unit range. And again, it's just uncommon to see active bleeding, but high density is not uncommon. Now we talk about, and we'll look at some examples over time, size and CT attenuation of hemorrhage decreases, can reach fluid density. The adrenal can get back almost to its normal shape, but not uncommonly it still has somewhat of a rounded appearance, and calcifications either in the rim or diffusely can indeed be seen. So it's a very important diagnosis. Chronic hemorrhage may appear as adrenal atrophy or as a hemorrhagic adrenal pseudocyst. It's interesting with adrenal atrophy, commonly those are the cases with the adrenal being calcified. Hemorrhagic adrenal pseudocyst is a chronic organized collection of hemorrhage that presents as a non-enhancing, thin-rimmed cystic structure. At CT, pseudocysts are non-enhancing and of central hypoattenuation close to that of simple fluid, but that's not always the case. In many cases, it's a higher density, so it's not going to measure fluid as in zero. Then your diagnosis tends to focus on an adrenal cyst, but it tends to measure 30 to 40 Hounsfield units. And then I'm looking at a cystic lesion that's 5 centimeters. I'm not exactly sure what it should be. Patients may have some symptoms or they may be asymptomatic, but what do? You don't want to biopsy these lesions. Do you leave them alone? Do you do something? What exactly do you do? The frequency with which adrenal hemorrhage is associated with an underlying tumor has not been well described, And again, we talk about occurring with PHEOs most commonly. We talk about metastasis. When you have obviously a primary tumor in, let's say, lung or let's say kidney, and you see an adrenal lesion, of course, then, you tend to think about it a little bit differently. But again, it becomes a very important thing to consider. And it is a very good challenge. Jordan also makes the point in his article, the rapid development or evolution of a non-enhancing adrenal mass, or masses that retain an adrenal shape, or perhaps have high T1 intensity and MR, can be associated with acute bleeding. Bilateral hemorrhage, again, can cause adrenal insufficiency, but more commonly we'll see unilateral hemorrhage. But if you see bilateral hemorrhage, again, you need to be very astute, suggesting Addisonian crisis. Imaging findings that suggest underlying tumors as a cause of hemorrhage are intralesional calcification, enhancement or hypermetabolic activity on PET images. I think one of the challenges, and I'll show you some examples, when lesions spontaneously bleed, every once in a while you can recognize a tumor underneath the lesion, but in most cases you can't. Incidental lesions are found in up to 10% of the population. Presence and pattern of calcification in conjunction with other clinical and imaging features such as soft tissue attenuation, enhancement, unilateral or bilateral, can aid in narrowing down a differential diagnosis. Calcified lesions can be categorized. Again, function becomes important, normal function, hyperfunctioning tissue, or insufficiency. So I think one of the things that, again, we talk about with many things in the adrenal, including incidental lesions in general, is looking at adrenal function. If you have a calcified mass, then most likely it's probably not going to be critical. It's unilateral, it's maybe old hemorrhage, old infection. Adrenal function will probably be okay. But if you have acute bleeding, you could think of many causes, including malignancy, including PHEO, and including stress or anticoagulant therapy. So there's a lot of things to think about. The challenge is, how do you be specific? And I think from a clinical perspective, the answer is surgery versus no surgery. And so can I help make the correct answer? So that becomes very, very important. So let's look a little bit more specific. Okay, etiology, Coumadin. Here's a classic bleed, unilateral. The adrenal's large, is high density, and there's minimal stranding around the gland. Patient was on Coumadin. Another patient, here round, high density, there's more periadrenal fluid or blood present. Again, a very nice example. Due to Coumadin, if you told me this patient had trauma, I would say absolutely possibility. In this case, the contralateral adrenal is seen and appears normal. So a really nice example of adrenal hemorrhage, and in this case, it was due to Coumadin. In terms of specificity, could you look at this and say it was Coumadin? The answer is no. I don't see any other sites of bleeding. It's unilateral, but again, differential diagnosis would always make me think of that possibility. So a very important diagnosis. And again, nicely shown this case in the coronal views. And again, kind of that oval appearance, the minimal stranding, the high density, definitely adrenal hemorrhage. Again, you'd be thinking about the differential diagnosis as we discussed. And over time, in this case, the adrenal got back its normal shape. It's interesting, obviously, if you have an underlying tumor, you're not going to get normal shape if you bled. But if you bleed from Coumadin, although it can calcify peripherally or diffusely, in many of the cases, it will get back to normal within a several-month period. Now, another case. Here you can see bilateral adrenal hemorrhage. This was also due to anticoagulant therapy, high density, oval, minimal stranding. You would go through a differential of what else this could be, anywhere from sepsis to DIC to metastasis. But again, Mets can bleed, but it would be exceedingly rare to have Mets bleed in both adrenal glands. I can't remember that at all. So when I see bilateral adrenal lesions, I'm always thinking about Coumadin or some other anticoagulant therapy. Here it is very nicely shown bilaterally on the coronal views. So a very, very nice example of bilateral adrenal hemorrhage. So we think about this, and again, in your mind, when you saw this case, you would go through a whole differential. You would talk about, okay, metastasis. You would talk about adenomas. You would talk about pheochromocytomas, metastasis. You would talk about a lot of things, but the high density and the stranding really puts you in the adrenal bleed, and all things being considered, you'd be looking at the patient's medication list. Now again, just a few more examples showing the bilateral adrenal hemorrhage. Now, another cause is trauma. Now, the thing about trauma is the patient typically has a history. The patient fell 3 stories. I mentioned before also, hemorrhage is most common in the right adrenal gland and often associated with a liver injury or renal injury. In this case, you can see hematoma, the high density left adrenal gland, large bleed. The right adrenal, you can see, looks okay. There's blood tracking around the kidney. You look carefully also for spine injury, spleen injury, kidney injury. You can see it very nicely here. Now, if you did not have a history of trauma, you would go through the differential diagnosis of an adrenal bleed. And in this case, you even thought about the possibility of a mass that was underlying that bled. But with trauma, that was the cause. The blood tracks by the kidney into the retroperitoneum and around the peri and pararenal space. And again, very nicely shown to you on these coronal views. Another example, this patient was post-trauma, had liver injury, had surgery, very dense, round right adrenal gland, classic adrenal hemorrhage. Now, another thing to think about is stress. Now, stress is not preparing for a lecture or giving a talk, or stress is really patients who are septic, who are post-op. Those are the patients you need to think about. This patient had a brain tumor which was benign. Surgery went well, but the patient was doing poorly. The CT scan was done to look for intra-abdominal abscess. They had no idea why the patient was doing poorly. Well, when you look at the CT, there are bilateral adrenal masses present. They're high density, they're round. This is classic bleed. This patient, we said, could this patient be doing poorly because they have Addisonian crisis because of lack of adrenal function due to bilateral hemorrhage, which indeed was the case. The patient was given hormonal therapy and did fine. So again, in a hospitalized patient, in a patient with recent surgery, you start seeing high density on this non-contrast study. Round, oval, stranding, it's a bleed, and stress is a good cause. And again, you want to make certain the patient has adrenal function and is not Addisonian. And with bilateral bleeds, you're probably going to have adrenal hypofunction. Now, underlying tumors. Now, underlying tumors are a very important cause and are a very challenging example. Now, we're kind of running out of time for this first session, but let me just make the point that there are a number of masses with hemorrhage, pheo being the most common, but even in that case, it's only about 10%. You can see there are benign lesions like adenomas and myelolipomas here, or primary tumors, metastasis, or ACC. So when you think about bleeding in the adrenal gland, you really need to think of a number of things. So I'll tell you what, time is kind of running out for the session. Let's stop here, get a cup of coffee, and come back in a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.